Thank you. Can you see my slides properly?
Yeah, perfectly.
Great. Yes, we move on to psychiatry, and a lot has been said already this morning by the wonderful talk of Marcel Romanus, and we had, of course, a discussion with Professor Elias. So I hope to be able to add something new. And what I want to start with is, why do we need so much attention for psychiatry in the period of the transition to adulthood? And as you can see on this slide, that this phase of life around the age of 18 in general is a very vulnerable period for psychiatric problems. The majority of psychiatric problems start at a young age, and particularly around the age of 18, when a lot of changes in somebody's lives already happening, we see the emergence of a lot of psychiatric disorder. And it's not only that people have psychiatric problems, but also the disease burden. So the cost and the years of loss of disability associated with it are higher around this early adult phase compared to other phases of life. So actually what we say is that psychiatric disorders are the chronic disorders of young people, whereas, for example, neurological disorders or cardiovascular disorders are the chronic disorders of people later in life. So just around that age of 18, we need to focus on mental disorders, on psychiatric disorders. And just then, as I think you all know across Europe, our system is at its weakest because a lot of changes are happening that people have to go through. And this is...
Excuse me.
Oh, yes, if you're already vulnerable as a person, like somebody with 22q11 deletion syndrome is, these changes around the age of 18 are even more problematic, and the tight coordination between pediatric and adult mental health care is even more crucial. So, for example, what happens if you becoming 18 as an adult with 22q11 deletion syndrome? The clinical practice is changing. For example, what is one of the more difficult things is the transition from a pediatrician to individual medical specialists. Because adult care, usually there's not a lot of coordination that somebody will take the lead. And during childhood, the pediatrician is usually taking the lead. And so this is sometimes really problematic, particularly if there are several medical issues and lots of different specialists have to be consultant. But the psychiatrist also, we have a transition to go to from a child psychiatrist to an adult psychiatrist. Dentists and GPs remain the same, and parents may join, but sometimes people say, I don't want my parents to be there. So that's also often complicating the management. Fortunately, most patients with 22q11 deletion syndrome, in my experience, are very happy that the family is there. But it happens occasionally that this is not the case. Also, people may drop out of treatment, and this is not always a choice of the families themselves, but sometimes the system is just not friendly for adults with genetic disorders or complex disorders. Then there are discussions about leaving the parental home. When are you going to do that? And how are you going to do that? And in the workshop afterwards with Daniela, we can talk about it more. Financial issues. Every country has their own system, but in the Netherlands, suddenly insurances policies changes. And what do people need to do? Are they able to work, or are they able to have some adapted income support? Also, that are issues that in the Netherlands are very bureaucratic procedures that we need to, that take a long time to arrange that and can cause a lot of stress for the whole family. Schooling is stopping. What are people going to do after they finish school? So these are all kind of things that also have an effect on psychiatric symptoms. So what I see often in the room is that there is, and this is something Anne Lawyer already talked about earlier on, this invisible disability. Like some people with Down syndrome, they're obvious that people can take care of, the recognition of what they're able of. But with people with 22q11 deletion syndrome, it's not always obvious what they are capable of or what they are not. So sometimes the environment, including their own family, sometimes is often unaware about what their strengths and weaknesses are. And they're sometimes, we call it overestimation. This is literally translated from the Netherlands, with a result of failure experiences, sometimes trying to work or trying to study and failure, which has an effect on their self-esteem and their mood and anxiety. Fatigue, Erik Boot mentioned it already, and weight gain, pain in joints. These are things that they come and that all affect also their mental well-being. And also sometimes medically unexplained physical symptoms, like seizures that the neurologists don't call epilepsy, or dissociation that are conversion-like symptoms that there are no medical explanations for by the specialists. So this slide was already shown by Dr. Romanus this morning, but the paper that Maud Schneider wrote a couple of years ago, and that is highly cited, clearly shows the dynamics of the emergence of psychiatric disorders across the lifespan. So particularly in adulthood, we are seeing a lot of psychosis, but also still a lot of anxiety and mood disorders. And what I want to highlight here is that we actually, I think, ignore the presence of PTSD, post-traumatic stress disorder. In the current literature, this has been rated with a very low percentage, lower than the general population, whereas our own data, and these are are still unpublished, we see actually an increased prevalence of post-traumatic stress disorder and also an increased prevalence of traumatic life events. And this can have consequences for management. But what I sometimes see is that I see people that are with a lot of antipsychotic medication and hearing voices, but then when you really take time to properly ask about what's going on, sometimes this is related to some past traumatic events that hadn't been recognized yet. And sometimes this is also are events that for us seem trivial or not so obvious, but for people with 22q11 deletion syndrome may have become a very big thing that keep them awake and causing nightmares. Good news is that we have seen that there's a low prevalence of substance use in people with 22q11 deletion syndrome, and that concerns smoking, drug use, and alcohol use, lower than the general population and lower than people with psychosis. So when it comes to management, we had already some discussion about it earlier on with Professor Elias. Generally, the recommendations are treat according to the regular clinical guidelines. And there hasn't been sufficient evidence. There haven't been any clinical trials, particularly for 22q11 deletion syndrome, not a lot, but work by Professor Elias' lab and also by Dr. Doron Gotthelf's lab in Israel really show that SSRI treatment, for example, in the case of anxiety and depression, is safe and effective. And the same counts for antipsychotic medication in psychosis, sometimes in combination with mood stabilizers or anti-epileptic drugs. And generally, for both psychosis, as anxiety and depressive disorders, non-pharmacological treatment are effective and recommended in the guidelines, at least in the Dutch guidelines. Also, CBT has been proven useful for people with psychosis and at risk of psychosis, according to Professor Mark van der Graaf's work in the Netherlands. And what it has is a continuous point of attention is the level of intellectual ability. And Dr. Fiksinski already mentioned something about keep on monitoring them, because just in case there is a decline, which happened in some people with 22q11 deletion syndrome, you need to change the level of daily activities, because if they have too much pressure, that can also cause or maintain psychiatric symptoms. And then one thing that really is important, and I find myself every clinic having discussions about this, is to involve the environment, and that means education, education about the syndrome, and that means education, the people that are involved in the daycare, the other doctors, the GPs, erase awareness and focus on stress reduction. And this can be done by offering structure, taking rest at set times. And the other thing also, and that was already mentioned by Dr. Boot, is pay attention to positive things. What does work for somebody? And sometimes that is having an animal or doing work with animals or listening to music or horse riding. So, just pay attention to and look for the things that are having a positive effect. And because then that can make a difference in somebody's life. I want to mention, this was also mentioned by Professor Romanos this morning. We last year did a study with a group of European researchers and looked what in general are good interventions to promote mental health in young people up to the age of 35. This was looked at, and this was a systematic review and meta-analysis. And what came out that sometimes very simple, the most effective was actually psychoeducation was most effective for mental health. And so we have, and these are very, very simple interventions that we can do to improve mental well-being and prevent maybe psychological symptoms. I want to say a few words about stress, because this has been mentioned several times. Stress is a word that is used everywhere and also here today and yesterday. And stress is something that we all experience. So I want to just say that avoid stress 100% is not possible and not realistic and also not desirable, because we all need a little bit of stress. And stress is a bodily tension, and that is happening in a response to external stimuli. For example, I having to present here, particularly seeing that my face was disappearing, so that causes me stress. So we all have a little bit of stress, which is normal. That can also be motivational and also add to positive challenge. However, if you have too much of it, it can be overwhelming and doing a lot of harm. And with stress, when we talk about stress, we have to differentiate between the exposure of stress, like if there is a flooding happening or a nature devastative event, earthquake, that's exposure. That's something that we cannot control. And the other thing is the response to stimuli. Everybody will respond differently to stressful situations. And that depends on coping skills. And we have like acute bodily response, that is our autonomic nervous system. That's something actually that I think we should investigate more in the future in 22q11 deletion syndrome, because that's modulated by one of the neurotransmitters that is also relevant for 22q. And a slow response, that is the cortisol response. And if you have prolonged stress or perceived stress too long, this can result also in, for example, weaker immune system. It can cause memory deficits and also can affect the risk for psychiatric problems. Now, what I want to demonstrate here is what we did. We looked at stress response and measuring stress in daily life. So in the normal day-to-day environment. And we did that by giving people an app on their telephone. And then during 6 days, ask questions and ask about where are you? Do you experience stress? Are you alone? Are you with somebody? And at the same time, people were with a mouth swab spitting on that, so we could measure the cortisol. And what we saw, and this we did together with Maud Schneider also, is that people with 22q11 deletion syndrome experience more negative emotions generally. And they don't experience less positive emotions, but they experience more negative emotions. And what they perceive more stress, although the questionnaires we were using, there were no more live events in our sample, but that maybe also says something about the type of questionnaires we use, but they did perceive much more stress than control people. And if we looked at the cortisol, we found the same slope compared to controls. So the normal pattern of cortisol was the same. However, there were much lower cortisol levels. And that could be related to the fact that they have experienced chronic stress. And that can cause like a blunt of the cortisol response. So in conclusion, I think considering the vulnerability, particularly in young adulthood, it's very important to have at least one psychiatric consultation in everybody who becomes an adult with 22q11 deletion syndrome. And maybe once is enough, depending on the situation. I think it's very important to raise awareness in the environment and educate our colleagues also about it. And the guidelines that Erik Boot was showing, I send them to every referrer, every GP that refers a patient to me, I'll send the guidelines. Then try to reduce stress by, for example, providing structure and rest, improve coping skills. That's easier said than done. But there are several training programs, at least in our country, that are, for example, dealing with improving resilience, dealing with trying to increase social skills, and these are also given in people with intellectual disabilities. So there are a lot of training that can be tailor-made, and pay attention to positive experience and try to see what does work. This is our center in Maastricht, and we have a multidisciplinary clinic, what Dr. Boot was hinting already, where we see as a team the patients, and it's together with an ophthalmologist, a neurologist, an ENT doctor, and an orthopedic surgeon. And I want to end just to give one slide about our patient organization. I don't think they're present here today, but they really have spent a lot of time in raising awareness, and very successfully. So for example, they've managed to get billboards about 22q11 deletion syndrome on the highways in the Netherlands, on the soccer matches, as you see on the right pictures, of the professional soccer competition. And tomorrow there's even a TV appearance by somebody with 22q11 deletion syndrome that participates in a TV show, and this is the second time. So it's all to raise more awareness and knowledge about 22q11 deletion syndrome. And I think right after here, but I don't know what